So it's my pleasure now to introduce the first of the presidential lectures. The presidential lectures were created in honor of our two founding fathers of the Movement Disorder Society, Professor Stanley Fahn and C. David Marsden. So Professor Fahn was the first president of the MDS. The Stanley Fahn Lecture Award was created to recognize an outstanding scholar and role model clinician in the field of movement disorders. The selected lecturer must show evidence of exceptional contributions which have resulted in better understanding of the cause, diagnosis, or treatment of movement disorders, and have translated into meaningful improvements in the standard of clinical practice. It's my great pleasure and honor to introduce this year's recipient of the award, Professor Carolyn Tanner. So Professor Tanner is in the Department of Neurology at the Wheel Institute for Neurosciences at UCSF, and she will lecture us on From Populations to Precision Medicine, Progress Towards Prevention of Parkinson's Disease. So Professor Tanner.
Thank you very much. Whoops. All right. So I'd like to begin by just taking a few moments to talk about our Stan Fahn. I think without Stan's contributions, none of us would be here, at least not in quite the same way as we are today. As we just heard, he is a founder of our organization and really one of the founders of our field in so many ways. The field of movement disorders relates back to his observations. I knew him best personally through the Parkinson Study Group, which was another one of his contributions with Ira Scholzen. He founded a clinical trials network that established high-quality clinical trials for Parkinson's, but also became a model for many neurologic disorders and other disorders in terms of quality trials for people with very specific high-quality standards. And more than that, Stan was a mentor to so many of us, an example, but also a personal mentor. I was never his real trainee, but when I had questions or times when I needed a little bit of advice, I could go to him, and he was always available and always thoughtful and always gave me really good suggestions. But he also paid attention, and if I did something that he thought was a good thing, he would reach out and say, that was a good job. He was an amazing person and played that role for so many of us. So it's just been a real privilege to be able to be in his association for all these many years, and a real honor to be able to give this lecture named for him today. The objectives of my lecture are, first of all, to identify approaches for primary, secondary, and tertiary prevention of Parkinson's, and then to apply these in the application of precision medicine to disease prevention. So the global burden of Parkinson's is projected to increase over the next several decades, projected as much as 17.5 million people worldwide by 2040, with a consequent economic burden. This is just a projection for Parkinson's in the US of more than $80 billion in direct and indirect costs by the year 2037. So clearly an imperative to address this issue, and the World Health Organization has identified a number of workable avenues for action. Today, I'll focus specifically on the third one they identified, prevention and risk reduction, because much of my career has really focused in this area. So from the perspective of public health perspective of prevention, there are three phases. The first is primary prevention. In this setting, we're trying to prevent the onset of disease. It doesn't even happen. So we need to identify causes and remove and protect against these before a disease process initiates. Secondary prevention, the pathogenesis has begun, but symptoms are not present. And so the idea here is to identify people really early and to be able to intervene before symptom onset. And then for tertiary prevention, we need to prevent consequences of disease once it's established. This is what we as clinicians do mostly at this point. And there's really a lot to do in this area as well. But obviously, it'd be better not to be in that tertiary prevention category if we could avoid it. Seemingly maybe a little bit in contrast from this public health population-based perspective, precision medicine focuses on very personalized treatment, the right person, the right time, incorporating genetic, environmental, and lifestyle characteristics. And the requirements to be able to really apply precision medicine in an effective way are risk stratification, early detection of pathophysiologic processes, and then interventions that target specific molecular processes in the individual. So back to public health perspectives of primary prevention, the first requirement is to identify causes. And this schematic just shows sort of large categories of causes that have been associated with Parkinson's. Almost none of these are absolute single causes. The genes associated with Parkinson's will be discussed quite eloquently by the next speaker. I'll just mention briefly, Mendelian genes probably account for about a third at most of people with Parkinson's, and for most of these, penetrance is reduced, so other factors, genetic and environmental, are also required. And then genome-wide studies have also identified many variants that have small contributions to risk. The other factors that are relevant are environmental, and I've spent a lot of time in my career looking at these, others as well. And so pesticides, solvents, air pollution, head injury, other categories of toxicant exposures, as well as factors that lower your risk of disease, conversely, like physical activity, healthy diet, intake of certain compounds or certain drugs can also be associated with lower disease risk. Trying to put these population observations into the context of an individual with precision medicine identifies the first requirement, which is risk stratification. And I'm going to talk a little bit about how some of our population-based observations can be applied in a precision medicine way to address risk stratification in an individual. I'm going to use two examples from my work and that of my colleagues. And the first of these is paraquat exposure. So paraquat is an herbicide. It's banned in the EU, in the UK, in China, and other places around the world. But in the US, use has been increasing, an estimated about 10 million pounds annually. And this diagram at the bottom, if I can show that, shows this is a bar chart that shows starting in 1992 and ending in 2018, the total amount of paraquat in million pounds used, so from 5 to more than 15 in 2018, which is the last data available on the USGS website. The little the colors are the different crops that it's used for. And then this is a map of the US, and the dark parts are the places where the highest density of paraquat use has been identified. So clearly used a lot in many, many different applications. Our first category of risk stratum or risk stratification is occupational risk. So this is a study that my colleagues and I did about 10 years ago, a little bit more, looking at farmers and their wives who were pesticide applicators, part of a prospective cohort called the Agricultural Health Study. And we evaluated people in their homes to verify their diagnosis of Parkinson's and took very detailed histories of their pesticide use, as well as other characteristics, lifestyle characteristics as well, and found that among the different pesticides that we studied, paraquat was associated with more than a twofold increased risk of Parkinson's disease, so an occupational risk stratification. But within those people who had that occupational risk, there were other factors that also affected whether or not they were likely to get Parkinson's. So the first of these is a behavioral risk. People who did not use good hygiene practices, who did not use personal protective equipment, were at a very high risk of developing Parkinson's if they used paraquat, fourfold increased in contrast to the 2.5 overall. And in contrast, people who followed a healthy diet, so a sort of an antioxidant diet, a Mediterranean type diet, were really not at a statistically increased risk of developing disease, even if they did use paraquat, while those who followed an unhealthy diet, sort of high in animal fats and processed food, were at a much higher risk, 4.5 times increased risk of Parkinson's. There were also genetic factors that were important in terms of determining whether or not people developed increased risk. One of these is the null of GSPT1, meaning people who were genetically unable to make this enzyme, which is a detoxification enzyme. And this occurs in about 20% of the population, so not uncommon. People who had this genetic characteristic were at about an 11-fold increased risk of developing Parkinson's if exposed to paraquat, if they mixed or applied it. And then later today, tomorrow, Sam Goldman is going to present some additional analyses in this population, looking at genome-wide burden tests in exposed individuals. What they found were that rare variants found through the whole genome association studies they conducted also influenced the risk of Parkinson's in people exposed to paraquat. And so go to Sam's poster to see the rest of that interesting observation. So putting this all together, the risk stratifications that we see for paraquat are first of all occupational, but then behavioral as well as genetic factors also being really important in the case of any one individual. The next example is trichloroethylene, or TCE. This is used as a solvent in many industries since the 1920s, and millions of pounds are used annually in the US, even more in the past when it had many other uses. Importantly, it's environmentally persistent. It's present in about a third of the water supplies in the United States, but it is not monitored. And another important concept, it's a volatile organic compound. So these plumes that you can see here in these maps from places around the country and the US, these plumes are subsurface, but they evaporate and then can concentrate in buildings. So in homes or offices, people can be exposed and not even be aware of the exposure. The first risk stratum for TCE was an occupational one. This was first reported by Don Gash in 2008. He looked at a small cluster of individuals in a plant who happened, some of them in his clinic, who had Parkinson's, and they went into the plant and examined others and found 14 more with Parkinsonian signs and symptoms, and found that they all were close to an open vapor degreasing vat that contained trichloroethylene. We then went and looked at a group of male twins who were discordant for Parkinson's disease. One had it, one did not, and took very detailed occupational job task-based histories. And then this was evaluated by an industrial hygienist who was not aware of disease status, but just looking at the job histories and assigning exposures to solvents like TCE and PCE, another chlorinated solvent. And in this population, TCE was associated with a 6-fold increased risk of Parkinson's disease. We're going to be talking about TCE for a while. Oh, here we go. Whoops. All right. The next exposure, and this is now moving from occupation to residence. So this is the TCE experience in Marine Base Camp Lejeune, where we have, starting in 1953, wells contaminated with TCE and other solvents. It wasn't even discovered until the 1980s, and the wells weren't closed until 1987. So there are a lot of service people and their families who were exposed to TCE at Marine Base Camp Lejeune. The ATSDR of the US government set up a cohort between 1975 to 1985 to look at this population and compare it to another population in Camp Pendleton where the water wasn't contaminated. During that period, the median water level of TCE was 366 micrograms per liter, and the top safe dose was 5 micrograms per liter. So significant contamination, drinking water, cooking, bathing, swimming, all those sources of exposure. We recently went back and looked at the population of members that were established in this ATSDR cohort for Parkinson's risk, finding people both from the Veterans Health Association medical record as well as Medicare, searching first by ICD codes, and then diagnoses were validated by review of all of the medical records. And Sam Goldman led this work, which many of us were involved in. Service members who worked at Camp Lejeune were about a 70% increased risk of developing Parkinson's compared to those who worked at Camp Pendleton, based on 430 cases of Parkinson's ascertained. And this is a young population, so still fairly early on in terms of the time in life of risk for Parkinson's. Interestingly, 57 others who were had other forms of neurodegenerative Parkinsonism were at similar risk in the two camps. So it seems to be really specific to people with Parkinson's disease. And then another example of this kind of environmental or residential risk is going to be presented later today by Megan Pollock and her colleagues. And they evaluated a population of attorneys where they noticed what appeared to be possibly a cluster of Parkinson's in a group of attorneys who were working in a particular law office, and then realized that that law office was right next to a contaminated site where a dry cleaner had a spill, and TCE evaporated and bioconcentrated vapor in the building where they were practicing. So they had that group of attorneys and a comparison group of attorneys not working in that building. What they found was that Parkinson's, MSA, excuse me, or TCE-associated cancers were found in about a quarter of the attorneys working in their building near to the contaminated site, but only 70% or 7% of the comparison attorneys. So again, an example of risk stratification for those individuals because of their place of work, but an environmental exposure or residential exposure. Thank you very much. I appreciate it. So this little schematic we published a couple of years ago shows the plausibility of both these environmental exposures like TCE or paraquat or others shown in black in the little boxes, and then genetic factors shown in blue because of their similarities in terms of their effects on the mechanisms thought to be related to the development of Parkinson's, like complex 1 inhibition, oxidative stress, synuclein aggregation, and then effects on the autosomal, autophagy and lysosomal pathways. So putting back to the idea of precision medicine, my recommendation is that we include in risk stratification exposure risks and not just risks related to genetic susceptibility. The next requirement of precision medicine is early detection of pathophysiologic processes. And we're all very familiar with the concept of prodromal Parkinsonism, where we identify people we think are soon to be here at the point of diagnosis by identifying other features that are associated with the years prior to the onset of Parkinson's disease. And I'll talk today just about one example, hyposmia. Many people are familiar with the really important work of Ken Merrick, Dana Jennings, Andrew Sidoroff, and others in the PARS cohort, identifying the fact that people who had an abnormal sense of smell based on a smell identification test and abnormalities of dopamine transporter imaging as identified by DAT scan, when they had both of these, they were much more likely to phenoconvert to Parkinson's disease within a couple of years. So a really important observation in a small group of people. And in this meeting, Ethan Brown, our colleague, will be presenting a sort of grander application of this same principle, trying to identify people who may be at risk for imminently developing Parkinson's disease, beginning with smell identification tests applied to people age 60 or older who didn't have Parkinson's, identified from many different kinds of settings, online settings, in clinic, advertisements, but mostly people not from clinical sites. And more than 17,000 people were invited, 11,000 and plus completed upsits. About 25% of those have abnormalities in the 15th percentile or less, and were invited, some of them, to have DAT scans. And of those who had DAT scans, about 17% were found to have abnormalities of 65% or less than expected. So in that group, expected to go on to get Parkinson's within a short period of time, a couple of years. So they're now going to be followed longitudinally in the PPMI study. Applying the same principle, going back to the exposed population who lived at Camp Lejeune, we were able to look at just ICD codes. And looking at ICD codes for some of these prodromal features, people who had lived at Lejeune were more likely to have olfactory impairment, anxiety, or depression, so prodromal Parkinson's features and others, than people who lived at Camp Pendleton, a little bit of an increased risk, 12%, 8%. And applying the MDS prodromal risk score based on these ICD codes, they were also more likely to qualify as being at risk based on the MDS prodromal risk score if they lived in that Camp Lejeune base where they were exposed to DCE. So this is important, and I think a way we can start applying these ideas to identify people early and apply the principles of precision medicine, but can we do better? And we all remember the history of Lewy bodies, the pathology of paralysis agitans identified almost more than 100 years ago now. And the subsequent almost a decade or a century later, identifying alpha-synuclein gene, the first Parkinson's gene, relatively rare in terms of numbers of individuals, but sort of revolutionary in terms of identifying the importance of alpha-synuclein as a component of Lewy bodies and Lewy neurites. And now, we've already heard about this from some of the awards, the alpha-synuclein seeding aggregation assay provides a new look into a way that we may be able to biologically characterize individuals who may have be at risk for Parkinson's, or certainly those who do have Parkinson's. So looking at CSF seeding assays, seeding aggregation assays, people with Parkinson's can be identified very effectively from controls, but also importantly, the sensitivity and specificity for separating people with other forms of neurodegenerative Parkinsonism, like PSP or cortical basal syndrome, is really very high, 84 to 94 sensitivity, 89 to 100 specificity. And interestingly, people with a clinical diagnosis of dementia with Lewy bodies have almost the exact same performances of between 90 and 100 of sensitivity and 94, 95, and 100 of specificity. So very, very high separations, both for healthy controls and then other forms of neurodegenerative Parkinsonism. And even more interesting, people with RBD, as compared to healthy controls, also have pretty good sensitivity, 64 to 100, depending on the population, and good specificity as well, 90 to 98%. Suggesting they may be one disease. And in fact, this is being proposed, and I recommend you to the session 2400 this afternoon, where Kathleen Poston will be discussing this as neuronal synuclein disease, defined by biology. So the presence of a disease-specific neuronal alpha-synuclein pathology followed or combined with dopaminergic neuronal degeneration to constitute NSD, or neuronal synuclein disease, with many different syndromes, Parkinsonism, DLB, neuropsychiatric syndromes, RBD syndromes, autonomic or hyposmic syndromes as well, many which will be overlapping, but which are defined molecularly by the biology. So applying principles of precision medicine to preventing neuronal synuclein disease, we now can rewrite our diagram and prevent NSD, which means in the beginning, it's the same. We don't want anything to happen, so we're preserving health, no synuclein abnormality. For secondary prevention, we now can identify people with an abnormality but no symptoms. And then, of course, tertiary prevention, the synuclein abnormality and certain symptoms are present. So focusing on secondary prevention, clearly our goal, a little more feasibility, proof of principle, is that when you add one more diagram to Ethan's stage screening paradigm, what we can find is that individuals who were had abnormal findings on dopamine transporter imaging and then had synuclein testing also were SAA positive. And many of these are people who actually didn't have symptoms, because some of the people who had abnormal upsets, only about half of them had symptoms. So suggesting that there's some plausibility to this early identification of individuals. So the next step is interventions that target specific molecular pathophysiology in an individual person. A lot of work has gone into thinking about this. I'll call out Michael Schwarzschild and Grace Crotty, who've organized a couple of meetings where people are really focused on how would we address the idea of prevention in Parkinson's, who would be the relevant populations, and then point you towards a poster that's going to be presented by Tanya Simoni this afternoon, looking at a specific application incorporating this idea of a specific disease stratification based on a biologically defined risk in individuals in the PPMI cohort who don't have Parkinson's disease, to be able to identify them for clinical trial evaluations of interventions that may delay the onset of motor or cognitive syndromes. And I'll just point out that this is a hopeful time for that. People sometimes say, oh, we don't have anything to do, but there are actually 63 disease-modifying therapy trials that were identified by Kevin McFarthing in this really nice review that was published earlier this year. So this whole half of this top circle are different trials that are targeting disease-modifying therapies with many, many different mechanisms. So I think it is a hopeful time, a lot of excitement about ways that we may be able to intervene. And then just as I end, I want to not completely neglect tertiary prevention. So these are the people who have symptoms and have synuclein abnormalities, and how can we then help them to prevent consequences of disease? And I'll take us back to the Camp Lejeune observation again. This is a poster that's being presented again later in this meeting by Sam Goldman, looking at the Lejeune population who do have Parkinson's, who are exposed. Their exposures have been characterized, and the people with exposures to volatile organic compounds are here in red, and those without exposure are in blue. And we looked at major PD progression milestones like falls, first fall, first fracture, onset of psychosis. And this is just looking at one of them, first fall. And you can see that it's not a good thing to be exposed to volatile organic compounds when you have Parkinson's, because you appear to have a much more rapid progression to bad outcomes in the context of your Parkinson's disease. So another important risk stratification factor, even in people with established disease. So what are our next steps? First of all, applying precision medicine principles are important for prevention and for treatment. This means incorporating from population observations, exposures. We don't really collect environmental or occupational histories routinely in our Parkinson's population. A lot of diseases do that. Cancer, it's a really standard thing. I think we should start doing that and start thinking about how that does affect our patients, both in terms of risk and in terms of progression. Similarly, behavioral histories. We can advise people even in terms of better behaviors, but first we have to ask them about them to be able to talk about it, and not just behaviors like, do you smoke cigarettes or not, but behaviors in terms of different hygiene practices as well, different types of exposures. And then we already do a reasonable job, I think, at genes. We definitely want to continue that. Genotype is also very important in terms of risk stratification. I think we're at a point where we'll be able to start incorporating additional biomarkers, including some of the other ones associated with neurodegeneration. But I argue that we should also incorporate markers of exposure to different environmental compounds. And there are ways that these can be done now, a little more focus in the lab, and we could do even better, I think. The microbiome is beginning to be recognized as very important. It may help us resist or be not resistant to exposure to exogenous toxicants, for example. So much more focus on that as well. And then we're moving rapidly to having better alpha-synuclein biomarkers. We've just heard about blood. That would certainly be easier to roll out than spinal fluid. Having quantification so that we could maybe measure progression as well. And then phenotype-specific characteristics. Maybe this will be true, maybe it won't, but it's possible at least that different conformations of the alpha-synuclein abnormal molecule may help determine which phenotype an individual is going to develop. And this would be an area, I think, important for research because it could help us again in terms of risk stratification. So my final statement is just that prevention is possible, and combining the principles of precision medicine and population-based risk stratification into individual specific risk profiles with biomarkers will be an important way to speed progression to prevent and reduce the global burden of Parkinson's. And with that, I'd just like to thank my many, many colleagues who contributed to this work. I can't name them all. thank the sponsors who supported it, and most importantly, thank volunteers and research participants, patients, controls, family, and friends for their many contributions. We couldn't figure out anything without their help. So thank you very much.
So you need to get the plug.
Oh, okay.
Okay, so let's go to this spot because then we can have a nice